Let's see, this mic does work, fantastic. So I was asked to be myself. So if you come to where I work, this is kind of how I dress. And I was asked to think big. So evidence-based decision-making versus decision-based evidence-making. Decision-based evidence-making is actually a term, and it's a negative term typically. So this is what political parties of the day do when they get into government. Based on their philosophies, they make a decision, and then they collect evidence to support that decision. Or maybe you might think senior management does this too. The decision comes from the sky somewhere, and then they present to you the evidence after it, the good evidence that comes out of it. I hope to change your mind a little bit around that. So this picture kind of comes to mind about all the evidence that's out there. Oh my goodness. And we have to use all that to potentially unlock some funding to provide therapies to patients. So hopefully, I'd like you to be able to discuss what elements are used in making these decisions, describe hard versus surrogate outcomes, describe perspective and very basic pharmacoeconomics, because I can describe very basic pharmacoeconomics, probably not complicated pharmacoeconomics, and describe an approach to creating evidence after deciding to add a drug to formulary. This is my Datsun 510. Actually, Sheila and my Datsun 510. Interestingly, we were married in Powell River, and this vehicle actually took us on a few dates to the Sleaman First Nation, their drive-in theater there. And it's actually very gratifying to see the progress that that First Nation has made and the pride that they've had in their own. And we actually, on our honeymoon, visited Savory Island, and that is the most tropical of Gulf Islands that we have. So if you have an opportunity to go there, and it's really quite shocking what the non-First Nations side of the island has become. Obviously, this was not a long-term solution, but for two recent graduates with student debt, this was a good choice at the time. But I started gathering, a list of what we'd really want in a vehicle, pros and cons, and I went out and I gathered, this is my personality, I gathered absolutely every piece of evidence possible. So I looked at crash tests, I looked at Lemonade Guide, I looked at all the different trucks and the warranties. We didn't really have spreadsheets back then that we used, but that's the kind of guy I am. So what car did we end up with? A Mazda B2200 truck. I'm pleased to say that truck still runs like a charm, and it's in my garage. That's evidence-based decision-making. My wife calls it annoying. Now, I also have the habit of revisiting that decision, seeing if that decision that we made still holds true. How did the other vehicles that I did not choose, how did they fare? So I'll term that evidence-based decision revisiting. My wife, however, calls that very annoying. Okay, back in 1930 in January, Clyde Tombaugh took 2 pictures of this particular section of sky based on a theory that another fellow had that planet X should be in this area of the sky. That theory was later proven incorrect. However, he took these 2 photographs, and those 2 little yellow arrows point to a dot of light that did not move with the other dots of light on that slide, thereby proving there was a 9th planet in our solar system. So that was the evidence we required to declare a planet a planet. It wasn't until 70 years later that the Hubble Space Telescope took this first color photograph of the planet Pluto, 900 million miles away. Of course, in 2006, we all know that the planet Pluto, the astronomers of the world met and decided that because Pluto did not attract into its gravitational field objects in its way, it was not a planet. so it was a dwarf planet. So demoted. So in that same year, NASA decided to spend $720 million to shoot the New Horizons probe out 900 million miles to get more evidence. May 29th of this year, this is what we had, a highly digitized photograph of Pluto. Not very good. July 1st, 9 million miles away, better. July 7th, 5 million miles away. Fantastic photographs. Beyond that, the evidence that is being collected by NASA in terms of the composition, the surface, the tectonic plates, an amazing amount of evidence. What does it mean for me? It means I can fill my presentations with nice slides at this point, but I don't know. That's science, right? And just amazing detailed photographs, and we've probably all seen these in the media. It takes up to 16 months to transmit all those photographs that it's collecting to us. This is the latest photograph of the planet Pluto, just a gorgeous photograph that it's hard to believe this is 900 million miles away, seeing huge ice mountains and landscapes. I would say that's decision-based evidence making. They decided to spend $720 million to shoot a probe out to collect evidence. We can argue all day whether that's a good decision or not, but that's an example of decision-based evidence making. So what about medicines and nephrology? First of all, erythropoietic stimulating agents. Observationally, we know that if people are anemic, they have to be transfusion dependent. There's a lot of poor outcomes associated with that. And so the layperson on the street would think if we could correct anemia, we would, and observationally, we should see things like reduced hospitalizations. We would see improved outcomes with respect to mortality. However, when those randomized controlled trials were done, we see that there's an improved quality of life for sure, but those other endpoints have eluded us. It's disappointing. However, we are avoiding transfusions and there's an improved quality of life. And of course, we still use these drugs. Moreover, those randomized controlled trials tell us that if we use too much of this drug, we get strokes, high blood pressure, and heart attacks. And in fact, we can aggravate certain cancers, head, neck, and lung. So we need to avoid using these in certain patients and certainly limit the dose. So we developed an anemia management protocol that gets people to target sooner and has them stay on target longer. And then the value of all those bad outcomes that we've avoided is really the value of the anemia management protocol. Phosphate, calcium, and PTH. My goodness, we're so good at chasing those numbers for about 45 years or so. But when we look at individual drugs that we use to do that, those hard endpoints of fractures, hospitalizations, mortality still eludes us. It's hard to make an individual agent or a change show that level of hard endpoint outcome, but they sure do change the numbers. So what does that all mean? And should we fund these drugs? In nephrology in particular, the greater relevance to our patients, there are fewer studies and less evidence available. We certainly use the primary literature, the drug trial, evidence-based medicine reviews such as Cochrane, if they apply to our population. Look at international and national guidelines. Some of those will be opinion-based, but evidence-based and expert opinion, that's okay. And the Common Drug Review here in Canada. So we analyze that published evidence. Are my patients represented? What benefit can I expect to see? Are there hard outcomes, such as the mortality, the hospitalizations, those strokes and heart attacks? And if there are surrogate markers, are they reasonable? A doubling of serum creatinine is a surrogate marker of time to dialysis because they couldn't run the study long enough. Is that reasonable? Here's a picture of my wallet. No. We spend public money, and so it's really important that we try to get it right. So from whose perspective is it worth it? If you're the patient not paying for it, it's probably worth it. Dollars spent versus dollars saved or avoided. So what's the cost avoidance? If the hospitalization costs this and the drug costs less, maybe that's worth it. Whose budget? If the renal agency buys a drug, but it saves on hospitalizations, but the PRA doesn't pay for those hospitalizations, why would we do that? Because we're altruistic, that's why. How does it compare to previous treatments? And is this the first therapy for that disease? So to help us out, we do budget impact analyses to figure out that. And it involves using population estimates to determine the potential added costs and also avoided costs. It helps with the choice, because if you have limited funds, if you say, I have $1 million to spend on this treatment, how are you going to do that? Are you going to spend up to the maximum amount with no restrictions and say, okay, that's it, no more? Or are you going to limit the expense to the most severe cases because we think that the most severe disease benefits the most from the drug? Do we place restrictions on the use so the people who actually get the drug are most like the people in the trial that demonstrated benefit? What if there's a lack of evidence but a strong patient or public demand for the drug? Unfortunately, for the last number of years, when we've reviewed a drug, I've never been impressed by the level of evidence that we're presented with. Certainly not as much as I had when I got the truck. So yeah, we'd like the trials specific to our patients and those hard outcome endpoints to direct us very easily to the decision, but increasingly those decisions are very difficult. Are patients likely to gain a symptomatic benefit? So if we can't hang the hat on the hard outcomes, do they feel better? Is their quality of life better? Is that something that we can get behind and fund the drug? Is it likely there's a benefit but not studied well or long enough? So we think there's something there, but the studies just didn't show it, which for the evidence-based folks in the crowd, you can throw stones anytime. Can we contribute to the published literature by creating evidence? So here in British Columbia, we have the PROMIS database, which we have laboratories, we have diagnoses, we have medications, thanks to the medication reconciliation program. It's all accurate. So we can tie those all together to see if our patients are actually deriving a benefit from the drug. And as Adira mentioned earlier, that's unique. And so can we use that as a leverage to actually contribute to the body of knowledge? An excellent example of this is the glomerulonephritis network. This is a disparate number of diseases that are rare enough not to have huge trials. But here in the province, maybe we can generate information to share to actually have a directed way of treating these diseases. And most recently, polycystic kidney disease challenges us because we don't even know how many people in British Columbia have this. So we have to get our heads around to define that population even before we go about doing a budget impact analysis. So that's getting involved in decision-based evidence making. Can we use the same approach to remove drugs from formulary? The FDA tells us that quinine is associated with a number of severe outcomes and has advised against using quinine in our population. The World Health Organization also has pleaded with healthcare providers to limit this drug to malaria. So should we be using and funding this drug in British Columbia? Can we use a systematic approach to deprescribing drugs in a given patient? So at the patient level, do they really fit the trials that for the drugs they're on? We're very good at adding drugs to patients, but we're not very good at removing them. Can we use this approach to deprescribe? A little bit about pharmacoeconomics. There's a number of terms around this, and I won't go into those, thankfully, I'm sure. So if this is our treatment, that dot on the screen, and this is its relative effectiveness, and this is the cost of that treatment along that continuum. If it's in this quadrant, it's less expensive and more effective. And I think you would agree that's a fairly easy decision to make. If it's more costly and less effective, that's probably equally an easy decision to make. If it's less costly and less effective, that's interesting. Maybe there are some patients that could benefit from that treatment whose disease isn't as severe or symptoms aren't as severe, and we'd be spending less money. However, we seem to be always in this quadrant. It's more expensive and supposedly more effective, and that's not an easy decision. So to help us with that, we draw this diagonal line through, and in that quadrant, that triangle, that's the incremental cost-effective ratio. So if you're in that zone, the effectiveness kind of, increased cost is outweighed by the increased effectiveness. What I haven't shown you here is safety. So what if it's less effective, more expensive, but it's way more safe? See how that plays into the decision? Those are just 3 of the parameters we use in a sea of evidence that we're presented with. Increasingly, that little diagram is in the left lower corner, and we're seeing treatments come along that are a lot more expensive and somewhat more expensive, or ridiculously expensive and way more effective. How can we actually afford these treatments? How can we limit our exposure, our liability in terms of the dollars we have available to us to contribute to these therapies? What if it's first in disease? Where does it fit on this scheme? We can't really compare it to anything. So we have to use the values of what we believe to be important for that disease. Equitable access to care. This is something I very much personally believe in, and as a tenant of the Renal Agency, that if we are confronted with these really expensive therapies and we don't have the budget for it, how do we go about providing equitable access? And do a few patients take the lion's share of the budget? Very interesting questions. What we try to do all the time is do things in a very open and transparent way as much as possible, and because we hope that we get your respect if we are honest, and that we work with integrity around all these issues. And I think the collaborative approach and as Adira said, all the committees are made of us, we are the agency, that when we make these decisions, they make sense to you. And also the trust of the patients and all of you, that they understand why decisions were made and it does make sense. Of course, history's, will judge us, whether we make the right decision or wrong decision, whether we approve an application or deny an application. But at the end of the day, the planet Pluto can be viewed, this whole thing, as the evil empire, that we make these decisions centrally, and how dare we, and we're this evil group of evildoers. But I would hope that you would actually see us this way, that we are trying to do the best job we can with limited evidence or with the evidence at hand, and we actually all work together to create that evidence to not only inform us, but inform the nephrology community beyond our BC borders. Thank you.